That's great. Okay, I'd like to get us started. We're just a few minutes behind on this penultimate session for the meeting. And this will be a little bit of a different format. The idea with this session is to have a panel discussion and importantly, a group discussion about issues in the career trajectories of individuals involved in being providers in these sorts of systems, whether they're physicians or not physicians. And I think the way we'd like, I think the reason this is so important, obviously, is that a lot of CCP is about relationships, right? And relationships work if they only if they work on both sides. And jobs are voluntary things; people don't have to stay in them. And yet, in a job like this, the longer you do stay in it, particularly in a given place, the more you can build those relationships. So I think what I'd like to do is just go down the panel, let everyone introduce themselves, their name, their institution, their role. Maybe if you want to take a minute or two and talk about issues that you think are important in sustainability or perspectives. Then we'll turn it over to the group to see what topics people would like to hear discussed. And then, if we get a chance, I have some additional questions I can draw on. And then eventually what we'd like to do after spending 20-ish, 25 minutes on those things is break out into a couple of tables for a little smaller discussions. Okay, so Joyce.
Okay, great. So I'm Joyce Tang. I am here based at University of Chicago. I've been here for about 8 years. I am trained as a general internist. I also have health services research training. So my role here is primarily clinical. I am a comprehensive care physician. I see my patients who are hospitalized in the morning. In the afternoon, I have clinic. The other roles that I have are education, research related roles. So a lot of those interests kind of really are based in my clinical work. So as you know, the clinical work is about the relationship. And so I bring that interest and those aspects of the program to my teaching. As a part of our longitudinal program, we have a patient-centered longitudinal experience that I developed where we pair our students with patients longitudinally. So they have that chance to really experience that long-term relationship. Research-wise, I do qualitative research with the CCP program. I also have the opportunity to work with our patient-centered advisory board. So 2 members are here today, Ms. Smith and Mr. Kindred. So I'm very blessed and happy to have them here join in the efforts. So that's a little bit about me.
That's great. Hi, everybody again. Niraj Mendrada. I'm from Permanente Medicine, Mid-Atlantic Permanente. My role is an assistant physician-in-chief of hospital strategy in DC, suburban Maryland. My favorite part of that is that I'm also chief for a complex care program. I am the principal investigator for our program as well. And program, which I kind of mentioned during my presentation, started in 2017. And believe it or not, we've had 0% attrition. Our physicians are there. In fact, I just hired another one for the Baltimore service area. And it's interesting that once the community starts to realize, the community of physicians and providers start to realize what we actually do, they come seeking that sort of work for us, because I think they find it gratifying. We get a lot of hospitalists asking about the program, because and I think one of the things they wonder about is what happens to patients when they leave from here, and until I see them again, what's going on? And I think they're intrigued about wanting to get in there and try to fix it. And so those are the type of physicians where we seem to attract a lot. Again, I think from an education standpoint, I've been able to recruit time for our residents to rotate with the complex care physicians. This really helps because I think the art of seeing patients at bedside is somewhat lost. And so when we reintroduce that as what we're doing just on a regular basis, they find that very intriguing. And some of the residents have now expressed some interest in doing additional rotations and maybe joining our team as well. And then again, I find that we have to keep on talking about our program and highlighting all the great things in order to keep it growing. Again, I'm really pleased that we've had 0 physicians ever leave the program. In fact, there's no mention of it. In fact, we're talking about growing the program even more, so that's great.
Excellent. Cressa Parrish, family practice physician, and retired about a year and a half ago and worked my entire career at Ingalls Hospital. I was the president of the medical staff and the associate director for the ACO, and I was a medical director for a local skilled nursing facility and assisted living facility. So, and I had a CCP model my entire career. Did home visits and then the skilled nursing and you know, basically from birth to death, was my scope as a family practitioner. And, I found it extremely rewarding. And I was, saying that I do these little presentations at the community garden. And, the most recent one, in September, included, medical student who is trying to determine what his specialty will be. And he was doing a rotation with CCP. And he said, I would just really like to talk to you a little bit about why you chose family practice. And I said, because I love the continuum of care and I love the continuity. And that's what I appreciate about the CCP model. And I said, it is deferred gratification. But when I retired, I have a scrapbook and I will cry almost when I talk about it, but these patients meant the world to me and I meant the world to some of them. And I got letters from them expressing that in ways that I didn't know they could. I mean, they should write novels. They're very good at expressing their emotions. And it was very gratifying to me to see that all that work that I had done all those years made such an impact. Even though you might not see it every day, it's huge in people's lives to have someone in their healthcare system be an advocate for them. And that's what I see. I was also saying that I think family can be defined in many ways. And I feel like this is family. This is what people are looking for to support them. You know, I've got your back. And I think the healthcare system can get muddled in the finances, but I think if we can stay strong and focus on what we believe is the most important thing, which is the health of our patients, not the diseases of our patients, that we can make a change. So I hope everybody sticks with it because it's really important.
I'm Nicole Gear. I'm a clinical social worker within the comprehensive care program. I came to this work 9 years ago. I was a recovering inpatient discharge planner. And excuse me. Niraj said I was super curious about like the folks that I was seeing over and over again and what was bringing them in. So I was so grateful to have found David in the comprehensive care program, and then was the only social worker in the program. And then we grew and evolved, and then became a manager in the program and grew from there. And then realized I had so many deficits in the ways of thinking about the suffering I was seeing, and so went back and got some training as a behavioral therapist and did a fellowship in that, started teaching at the Crown Social Work School and just building out different ways to understand the work while the program was growing and understanding that too. Our life and grew and changed, and we moved to the East Coast a few years ago, and so I transitioned into a different role within CCP, building out the programming, thinking about like behavioral health needs and how to design therapy in groups and things both in the virtual space, but also with patient feedback and input. You heard a little bit about my work thinking about how teams can communicate, how we can frame our commitments to one another. Done some research with Joyce and others, Ram, in the program on how to translate what we're doing and talk about what we're doing. So I'm really excited about continuing that, especially in the domains of self-compassion, burnout, and things that are super relevant, I think, to these models. And then lastly, I really enjoyed teaching interprofessional. So in Providence, in Rhode Island, where we're at Brown, I recently joined the M1, the medical school. They have a curriculum where a doctor and they call it social behavioral scientist, are chatting with first-year medical students about their journey, first-year teaching perspectives and ways to think about doctorate and become. So I think that's an interesting pathway where CCP is definitely launching. Oh, yes, and Ms. Smith is, my biggest advocate for the wellness group that we do in CCP, and that has been such great fun and a great opportunity to kind of put some of the principles we were talking about up here as the team that we do, with the.
I'm Nicole's husband. Oh, my name is Vinny DiMaggio. I'm one of the, I currently am a med peds physician core faculty with the residency at Brown University. I was a CCP from 2018 to 2021. I have academic interest in transitions of care from pediatrics to adult medicine, specifically for people with chronic diseases that now we're seeing there are more adults than youth, for like congenital heart disease, sickle cell disease, things like that. I was very lucky. David was a big champion. I'm eternally grateful for it. We tried to create a program out of the CCP model that we can probably have another 5-day retreat about all the payer issues and who we worked with and FQHCs and stuff. And we tried really hard, and then the pandemic hit, and I wasn't really doing a lot of pediatrics, which led me to Brown, where I've taken over a panel that was with one of the founders of the MedPeds Clinic. So I have patients that were with her for like 30 years, that I'm now, I think, applying a lot of our, they went from healthy children to now chronic diseases, and we're working on managing that. I'm also a hospitalist for pediatrics and adult medicine, and what we learned here is we're trying to apply there. Embedded primary care in a sickle cell clinic. So it's a little different model where I go to a specialty clinic and we try to figure out how to create continuity of care and prevent hospitalizations, and do a lot of the principles that we've gotten here.
Great, wonderful. So let me try to signal a little bit where we're headed in the breakout groups, and then that can frame at least what some of the smaller group discussions could be. But before we actually get there, we'll have opportunities for, whole group discussion. So the 3 breakout groups we have planned is Joyce and Vinny are going to talk about academic and education focused roles. As people know, academic institutions, clinical institutions have expectations about, publication or clinical productivity or other things. And there are obviously unique clinical challenges to this population. So that group's gonna focus on that. And then Niraj and Emily are gonna talk about clinical and community hospital settings. What is it like more clinically? And then Nicole and Nancy Galvez, our current social worker, are going to talk about social service workforce issues. So those should be hopefully discussions that we have in smaller groups. But I want to also hear from the group. Are there issues that people are interested in terms of discussing career sustainability that we haven't mentioned yet, that should be other discussions that we should have in parallel? Is there anything that leaps to mind with people? Yeah.
I'd love to explore the transitions of care more. I'm also med peds, and definitely I know, David, you alluded to it earlier, that transitions from childhood to adult is probably not as exposed to.
Okay, that's great. Other things that people would like to bring up? If not, let me sort of throw some questions out to the group. For not everyone has to answer, but what are the things that you all think are important when we're designing jobs like this to make them sustainable for providers?
I think it helps to point out, and this was brought up earlier in discussions, point out the positives when they occur, because they might not be very often, and that's where the burnout comes. You feel frustrated that you can't have a more positive impact, but when you do, I think it's something to be celebrated and communicated throughout the team. I think that helps a lot.
Yeah, well, I'll just share one thing we do in our monthly meetings is we start every single meeting with feedback from patients. And every once in a while, it's not that positive, but honestly, that's rare. Most of the time, it's really glowing and kind, and like you described with these letters. Actually wonder if you have a book of your letters that you should publish. It's identified, of course.
Oh, I don't know if patients would like that, but,
Yeah, maybe.
but I wanted to read one entire letter here. I just only had 10 minutes.
Yeah, well, again, in the 5-day version of this meeting, we're
Yeah.
hearing every word of that letter.
Yeah. Yeah.
Other things people wanted to comment about important things in designing the jobs.
Yeah, I think it's nice to have your own kind of niche or outlet for kind of creative pursuits. So there's so much that we do in the clinical arena that, you know, we can't solve a lot of the problems that we see. They seem almost like we talked a lot about the multiple challenges that might exist in certain situations. And so I think it's nice to have part of your time be able to be separate from that and thinking about either from an education perspective, from a research perspective, maybe from a kind of management or programmatic perspective. What are other ways to really approach those challenges that we're seeing? Or what are ways to educate our early learners to build the workforce that we want to see in the future? And I think that having some time to do that, having the space, the folks around that you can partner with. I think the interprofessional team is a really nice group to be able to kind of share different skills and different topics that people have expertise in. So I think that's been really nice. And I think that partnering with everyone that is around that's a stakeholder, so that includes patients, I think is critically important. And I think has been a big way to rejuvenate a lot of the work that I do.
Yeah, let me just comment for the people in the room who aren't academic physicians, just so that everyone, you know, understands maybe the subtext of what Joyce just said. There's increasing economic pressures on physicians in these settings to be very productive. If you are a primary care doctor, what that means is that you're seeing patients, you know, 9 half days a week or something like that. And, you know, maybe, and probably the other half day, you're cleaning up all the mess that didn't happen. If you're a hospitalist, you're seeing patients in the hospital probably half the year, which sounds like you kind of get half the year off, but these are very, very long days, but at least there's a little more room in there. And, you know, if you're not going to be seeing patients, then the expectation is you're somehow either in one of these very scarce institutional roles, which may or may not be an outlet for creativity, or and are very competitive to get, or you're seeking external funding, right? And so, you know, when Joyce describes having a niche or outlet for creative pursuits, that's not always an easy thing to find or create in these settings. One of the answers we've come up with is trying to train people earlier in their career so they have skills so that they can be able to do those things. But those are not common things in all settings, and they're not free either. So anyway, these are, I think this will be some of what the academic group, you know, talks about as some of the challenges. I want to touch on the clinical area just a little more. What are the things that create joy? What are the things that are challenging? We talked a little bit about celebrating the successes. You know, what else can we do to sort of, you know, grow the successes and help buffer the challenges? Like what's helped you in your lives doing those things?
So I think one thing I piggyback on, we've heard a lot, I think today about the two sides. I think there's a clinical way to do this, an academic way, and I think underlying both is important to have a mission. So, you know, David was very supportive, and having people around you that do that. I think David was very supportive of my mission to try to create this model for young adults and move them to the adult setting in a way that was safe and improved outcomes, and was an ally the whole time in facing the challenges, and has been very encouraging in my career, even outside the institution. And I think having that mission does bring some joy to the work. I think the relationships are very rewarding and challenging in their own right. And I can think of people that, you know, I still recall fondly, and some that even in challenging experiences, I had fond memories that we were even talking about a couple of minutes ago. And I think that does bring a lot to make the job more sustainable.
Great. Maybe just one more question for the panel, and then we'll throw it open to the groups. What are the things that sort of either professional organizations or larger institutions, you know, should or shouldn't do in terms of helping people sustain themselves in jobs like that, like this?
think for us, try as frequently as possible to meet with our frontline group that's doing this work. I mean, I think not just the physicians, but like the entire team. Meet with them, hear their ideas, encourage their ideas, nurture some of the ideas that, you know, and then also like we're big into doing pilot studies in our program, like even just for the heck of it, it doesn't mean anything. Let's try this for a month and let's report back on it. And I think just allow some autonomy and some gratification for the work that is being done to come to full fruition. And a lot of times I'm surprised that the ideas that our physicians have, if you give it a platform and give it time to grow, they are probably the best and most probably least expensive type of ideas. And it's always, again, for any organization, the top-down model is very bad. So you lead with them and you know, we can afford to do that in small programs like ours. And then again, to the point that now we've done it enough that we have like cardiology or nephrology or oncology coming to us and asking, what would a complex care program here look like? And so we look at that as a little bit of a win, at least that conversation's taking place. So again, I think communication is free. And if we can find a time and put it on the books to meet with our teams as frequently as possible. I know it's hard, but we do it. Our cadence is monthly, and then a larger group is quarterly. And sometimes we meet twice a month because we have important topics to discuss. So, and then some of these we've created a think tank in our group. So we have this. I guess it's a WhatsApp thread basically. It's funny because you know you can vent out on it and you can say, you know, complain about patients or complain about colleagues, and it's private and something we look to laugh with, but it's also used as a think tank. There's like ideas coming in every day. What if we did this? What if we approached this way? We use it for discussing complicated cases. But again, establish a forum where our frontline physicians and teams can express ideas and nurture them.
That's great. Anyone else?
I think on that, like generously fund continuing education, whatever that might look like on an interprofessional team. I mean, for me, I went back and trained as like a therapist within still working in CCP. And I think a lot of people would be like, why this set of skills? And had I been in any other role than this program, which was like open to diverse perspectives, I might not have had some of that support, but I had it. And I think that's just enriched my work and the team and the sustainability of my role. I grew, I felt like I could contribute new ideas and perspectives to the team. And so that would be one thing where as much as you can fund even trainings that seem like maybe not as relevant, they could be, and that could really help that person or the team contribute in a new way that's meaningful to them. And then the second piece, I think there's a tension in complex care programs around how lean is your team and versus how much support do you need. We've had various evolutions of our social service team and our physician team. And there's a benefit in being lean. There's a creativity and autonomy that I had when I was only social worker. And it's a lonely road sometimes. And having colleagues now to bounce ideas off of that are trained maybe from a similar mindset than me, it was so valuable. And not having them was valuable too, because then I had to look to other professional peers. So I think it's worth thinking about how long do you keep a single person in a role by themselves and how do you connect them to support versus what support are they getting from the other professionals. And like, can a physician mentor a social worker? Absolutely. And I've had physicians. I hope I've been a mentor.
And just two related comments. One is there's been an incredible amount of fluidity between jobs. What, you know, a social worker does one day, a physician may do another day, a community health worker may do the next day. And that's important for creating some of that sustainability and fluidity and also avoiding handoffs when you need to do them. And then the other interesting tension is sort of scale. It's hard to be a really small program. It's also depersonalizing in some way to be a super large program. So figuring out how to create pods of the right size and connect them and let them lean against each other is super important organizationally. So these have been great comments from my perspective. Let me suggest we break up into the three groups. One will be academic and education focused, which can be over there, political and community settings in the middle, and social service over here. Okay, and we can break up for probably about 20 minutes and then have a little bit of time for some reporting back. Okay, great.
Wonderful.